Guys, welcome back again to the series of color Doppler. Today's topic is role of color Doppler in portal hypertension. Before going into details of color Doppler for portal hypertension, what are the causes? There are three causes. One is prehepatic, second one is hepatic, and third is posthepatic. The prehepatic cause is due to thrombosis in the extrahepatic portal vein at the level of porta, which causes back pressure changes in the superior mesenteric vein and the splenic vein as a sign of portal hypertension. The second cause is hepatic cause due to cirrhosis of liver. When the hepatic normal sinusoids are replaced by the regenerating nodules, these nodules compress the portal channels and causes increased pressure in the portal vein, causing portal hypertension. And then the third cause is Budd-Chiari syndrome. Whenever there is thrombosis in IVC or the hepatic veins, that will also cause obstruction of the blood flow into the hepatic veins, and eventually back pressure changes will be in the portal vein, causing portal hypertension. Let us discuss the anatomy and physiology of the portal venous system. So this is a superior mesenteric vein which drains blood from the small intestine, and then there is a inferior mesenteric vein which drains blood from the large intestine and into the splenic vein, and these splenic vein and the superior mesenteric vein merge to form a portal vein. Left gastric vein from the stomach also drains into this portal vein, and this portal vein enters into the liver and divides into the right and left portal vein. Eventually the blood flows into the liver sinusoids, and after all the metabolism, the blood drains through the hepatic veins into the IVC. The left hepatic vein, middle and right hepatic vein into the IVC, and then eventually into the right atrium. Liver cirrhosis is the hepatic cause of portal hypertension. As you see here, this is the normal liver parenchyma and this is the cirrhotic liver. These regenerating nodules are compressing the portal channels, which are compressed, and the back pressure change will be seen in this main portal vein as a portal hypertension. It is very interesting to know that fetal circulation plays a very important role in case of portal hypertension. So how it happens? See, this is a diagram of fetal circulation. This is umbilical vein which drains fresh blood from the placenta, which meets the left branch of portal vein through the ductus venosus, and this ductus venosus meets the inferior vena cava and drains into the right atrium. So after the birth, this ductus venosus gets obliterated and we call it ligamentum venosum. Similarly, this umbilical vein also gets obliterated after the birth and we call them ligamentum teres. So what happens in case of portal hypertension? So in case of cirrhosis of liver, when there is back pressure changes in the main portal vein, this pressure gets diverted towards the splenic vein, towards the superior mesenteric vein, and towards the inferior mesenteric vein. Due to these back pressure changes, multiple collaterals start opening up. Gastroepiploic collateral goes towards the gastric fundus, and this coronary vein also opens up and forms gastric varices at the gastroesophageal junction. Another one, when the pressure will be more high, this umbilical vein which was obliterated and formed ligamentum teres reopens, and this blood goes into the umbilical vein towards the umbilicus, and through the collateral it drains into the inferior vena cava. Similarly, these collaterals, which is called linorenal collateral, which connects left kidney splenic vein to the left renal vein, the blood flows backwards and through the left renal veins finally drains into the IVC. Among all these collaterals, formation of linorenal collateral and opening of this umbilical vein has very good prognostic values. because now the pressure will be diverted towards the renal vein and it will finally drain into the IVC. But if this linorenal collaterals, the collaterals around the spleen is not formed and this umbilical vein is not opened up, then more of the pressure will be diverted toward the gastroesophageal junction, which will cause severe hematemesis in the patient. So opening of this umbilical vein and the linorenal collaterals are very good prognostic values in case of portal hypertension. We document the signs of portal hypertension on a gray scale and then on color Doppler. Among the grayscale findings, in case of prehepatic cause, you will find thrombus in the portal vein, and in cases of hepatic causes in liver cirrhosis, there will be coarse ecotexture of the liver with multiple nodules, regenerative nodules. In case of cirrhosis, the right lobe of liver will be smaller in size and there will be hypertrophy of the left and caudate lobe, which is indirect sign. Due to back pressure changes, there will be splenomegaly more than 13 centimeter, and there will be dilatation of portal vein measuring more than 13 millimeter. But remember, the normal caliber portal vein doesn't rule out portal hypertension, because in later stage of portal hypertension, due to decompensation, the portal venous diameter becomes normal. Then there will be dilated superior mesenteric vein more than 11 millimeter, which is the cutoff, and it is a definite sign of portal hypertension. Splenic vein be also be dilated more than 10 millimeter, but that is non-specific, could be also due to isolated splenomegaly, and opening of umbilical vein measuring more than 2 millimeter. So these are the vessels, and there will be free fluid in the peritoneal cavity due to hypoproteinemia and increased back pressure changes in the portal vein. And in case of post-hepatic in Budd-Chiari syndrome, you will find thrombosis in the IVC or the hepatic veins. So these are the grayscale findings. Color Doppler findings in hepatic causes due to cirrhosis. So there will be reversal of color flow in case of portal hypertension when it's established. In early stage, there will be high resistance flow in the main portal vein, but eventually there will be reversal and the normal red color of the main portal will become blue. The centripetal flow will become centrifugal and it will start showing blue color. In normal portal vein, there is a respiratory phasic variation which is seen in inspiration and expiration that might be lost, and there might be periportal cavernoma formation, linorenal collaterals, gastric varices, and you might see blood flow within the opened up umbilical vein, which is a sure short sign. The hepatic artery will start showing high resistance flow for the same reason, because the regenerated nodules will start compressing the hepatic sinusoids and the hepatic arterioles will be compressed, which will result into increased resistance in the hepatic artery, which will start showing high resistance flow. But the superior mesenteric artery will start showing low resistance, high velocity flow. It's just opposite. And the normal hepatic veins which show triphasic pattern due to cardiac cycle, which will be lost in case of hepatic cause also. And the color Doppler findings in case of prehepatic, when there is thrombus in the extrahepatic portal vein, there won't be any flow seen on the color flow imaging. And the hepatic artery which start compensating, because there is an obstruction in the main portal vein, there will be more flow towards the hepatic artery, so it will start showing low resistance, high velocity flow, just opposite of the cirrhotic cause, where there was a high resistance, increased resistance flow in the hepatic artery. In case of prehepatic cause, it will show low resistance, high velocity flow. Periportal cavernoma can be seen, and rest all the other color Doppler findings will be the same as in case of hepatic cause. In case of Budd-Chiari syndrome, when there is a thrombus in the hepatic vein or IVC, there will be loss of triphasicity, which is due to cardiac cycle, and if there is thrombus, then there will be no flow or flow reversal in case of involved hepatic veins. There will be formation of intrahepatic collateral due to thrombus in the hepatic veins, and if the thrombus is in the IVC, then the same findings will be there, no flow or flow reversal. Rest of the signs are same as in case of hepatic cause. So this is a chart, same just to compare. Portal vein diameter, as I told you earlier, was 9 to 13 normally. In portal hypertension, it will be more than 13. The velocity, which is normally up to 18 centimeter per second, will be reduced to 12 centimeter per second and below due to increased resistance. And as I told, respiratory variability will be lost, the flow will be reversed, and the portal vein volume will be also reduced. The splenic vein will show more than 10 millimeter diameter, and the superior mesenteric vein more than 12 meter, which is more specific. I told you earlier. And then the hepatic vein will become monophasic, and the hepatic artery will start showing increased peak systolic velocity due to high resistance. Now coming to the images. So this is a case of portal hypertension. You can see the flow is red, so it's towards liver. It is not reversed, but then you can see the upper margin of the spectrum is almost flattened. There is loss of normal respiratory physicity in this portal venous spectrum. And this is the late stage of portal hypertension, when you can see the flow, which should be red, has reversed to the blue, and there is reversal seen in this spectrum. Now it's going downwards. This is another case of portal hypertension, when you can see there are multiple periportal collateral seen due to portal hypertension called periportal cavernoma. And this is the characteristic sign of portal hypertension. When the umbilical vein has opened up, you can see the flow in this umbilical vein, which is opened up within the falciform ligament. This is the transverse section, and this is the longitudinal section. This is the flow in the umbilical vein. This is a lienorenal collateral. This is the spleen, and this is left kidney. You can see there is a collateral which is connected between the splenic vein into the left renal vein, lienorenal collateral. That was all about color Doppler findings in case of portal hypertension. But can we provide some intervention for treatment of this portal hypertension? Yes. One of that is TIPS, transjugular intrahepatic portosystemic shunting. So what we have learned, that due to portal hypertension, increased pressure in the portal vein, multiple collaterals are formed. One of the most sinister collateral is at the gastroesophageal junction, which causes gastric varices and causes severe hematemesis. And for that treatment, there is a stenting done between this IVC and the left portal vein. As I told you earlier, during the fetal period, there is a ductus venosus which connects the left portal vein with the IVC, which is obliterated as a ligamentum venosum. So this ligamentum venosum tract is used for TIPS. Stent is passed through the internal jugular vein to the right atrium and to the IVC, and then it's placed between the IVC and the left portal vein at the ductus venosus. This causes bypass of blood and the blood flow directly to the IVC through this TIPS, and which relieves eventually the formation of these collateral formation, and the patient is relieved of the hematemesis. Now this is the patient with TIPS. This is the axial scan. This is the longitudinal scan. You can see this flow is going into the IVC from this left portal vein. This is the IVC, and this is the left portal vein. This is the TIPS, and you can appreciate the high velocity flow in the TIPS. And this is post-tip change in the portal vein. In case of portal hypertension, which normally shows less than 12 centimeter per second of blood flow due to high resistance in the liver parenchyma, now due to bypass, this portal vein is show very high velocity flow around 60 centimeter per second. Low resistance, high velocity flow due to bypass. Similar findings in hepatic artery also, post-tips. Normally in case of portal hypertension, when the hepatic artery shows a high resistance, low velocity flow, Now due to TIPS, it's showing a high velocity, low resistance flow. It has got a very good diastolic component and the velocity is around 50 centimeter per second. Thank you very much. That was all about role of color Doppler in portal hypertension. I hope you'd have enjoyed this session and this would help you in your day-to-day life ultrasound practice. Thank you. Bye-bye.